Sometimes it's by author, sometimes it's by subject. By colour is a new one for me.
Here we go. Hi, everybody, and welcome to today's Facebook Live. Sorry, I was just catching up there with Mike Wilson, who I'm thrilled to be joined with today for our Facebook Live Q&A. But before I start, I'd like to acknowledge the traditional owners on the lands where we're meeting. I am in very rainy Melbourne today. It's beautiful Wurundjeri land, and I'd like to pay my respects to elders past, present, and emerging. Mike Wilson, CEO of JDRF, welcome to today's Facebook Q&A. How are you?
Very well, Renza. Good to see you again.
Great to see you too. Tell us about yourself. We haven't had you on one of these before. So who are you? What do you do? Where are you?
Well, I'm in Sydney right now. It's slightly warmer, not too much warmer, but a bit drier. I've got a bit more freedom. So our thoughts are with you in Melbourne and others who are unable to have that freedom of movement yet. Hopefully it's back pretty soon.
So,
I've been fortunate to be the CEO of JDRF Australia now coming up 16 years. And so I've found that I've got a job that's both a passion and a profession for me.
Yes.
It is professionally stimulating and challenging, but personally for me, I find it something that is actually motivating as a deep passion as well. So I work with great people, incredible board, and the most wonderful community, as you well know.
Very, very much. And like you and I have been working together then for 16 years. I've been in the Diabetes Australia family for a little bit longer than that, but we have worked together here in Australia. We have crossed paths at conferences overseas, and we very much have a shared passion, and that is to support the diabetes community in Australia and globally as well, with a focus because of JDRF's work. It certainly is a type 1 diabetes focus. I live with type 1 and have done so for 23 years now. So always very interested in the work that JDRF is doing. We've got so much that we could talk about, but today we're going to focus on a new report that JDRF launched last week. Could you tell us about that report, please?
Sure. So as we look to the things we're trying to achieve as JDRF, one of the things that struck us, we were using out-of-date economic data on type 1 in Australia. The wonderful DiabCost study, which many will know, and that Diabetes Australia was key to the conduct of, was 2009. And that was okay in 2012 and 2015. We thought that we really needed to reprise that and make it contemporary. It's even more important when you look at a world where fiscal constraint is the narrative across every political decision, and making an economic case, as well as a human case and a scientific case, is going to be essential for any big policy change. And we know that any big policy change in Australia in health generally needs government. So the economic analysis here, this report digs into what are the true costs to Australia, to individuals of type 1 diabetes, and what would some interventions and investments lead to in terms of reducing those costs and providing clinical benefits. So that's why we wanted this out there for people to use.
Great. And we'll drill down a little bit more, but just a reminder to people who are watching through Facebook Live right now, we'd love to take your questions. You can use the comment function and share any questions that you would like us to get to about this report and about the work that we do. But also, if there's anything that you would like to ask anonymously or not have your name read out or shared with others, you can send a message to Diabetes Australia, and somebody there will send me the message and I will be able to ask that. But Mike, that is so important, I think, because one of the things that we hear constantly is, how, or are asked of us constantly, is how do we get that message across about what needs to be done? And, people with lived experience can tell our stories, and we've got great evidence from health professionals, but we need this data as well, don't we, to sort of round out that picture?
Absolutely. I still believe there's nothing stronger than the lived experience coming from the hearts and minds and mouths of those affected. So that's got to be a foundation on which we build. But then other organizations and other conditions have that lived experience too. So we want to make sure that we get the level of attention and response that we really think is necessary and valid. That's where stuff like this economic information that really outlines the true economic, physical and mental cost and scale and burden of type 1 diabetes is going to be interesting to those who are making decisions. And that's why we've got a group like Accenture to do the work, real acknowledged experts. So it's seen not just as an internal best guess by JDRF or a group of well-meaning individuals. This is well-validated, expertly produced information that is going to be pretty similar to what the government will find when they put it through their own internal machinations.
Yeah, absolutely. And we'll talk a little later about what this means for, the person with diabetes and how we can use this. But before we do that, let's talk, was there anything that came out of this report or in the data that surprised you?
So I was actually surprised at the scale of the total annual cost, and particularly you break that down into annual and lifetime costs for people with type 1 diabetes. Now, that's through no fault of themselves, but that's something that the country should be paying attention to and investing in things like new technologies to help not just with clinical outcomes, but with cost effectiveness. So cost effectiveness is such a big and challenging topic, but really the message to me out of this was it's not just good for people, it's good for the economy. And if we can get those two things out in front of the people who make decisions, we can get some stuff done.
And that really is something that we know that when we're talking to our local MPs, they want to know about, don't they? And for us to be able to go and say, hey, this is how it affects me personally, but hey, this is how it's going to affect your budget, that really makes it quite strong, doesn't it?
It does. And when we come to the discussion of how we're going to use it, I've got something I can share with you there that gives you exactly what you're after to make it a compelling case.
Excellent. Good. Well, let's get to that. But actually, you know what? I didn't do something at the beginning that I should have. And I have a question from Theo. What does JDRF mean? Can you tell us what it stands for and tell us a little bit about JDRF?
Okay. We stand for everyone with type 1 diabetes. That's not the answer. That's a sidebar. But the history of JDRF was Juvenile Diabetes Research Foundation.
Yep.
Now, that was at the time the best thing we could think of, but unfortunately, it gives the misimpression that we're about people who are children with type 1 as opposed to all ages and all stages.
Yeah.
And the word juvenile diabetes is not well used much anymore anyway. So it's just a bit confusing. So we've done the IBM route. We've gone to the acronym.
Mm-hmm.
We couldn't think of anything better than JDRF as an acronym because everything else was taking us a bit further from our raison d'etre, which is a cure and in the meantime, better treatments and reduced burden and safety and day-to-day management for everyone with type 1 diabetes, no matter when they were diagnosed and no matter what their age is now.
Yeah, and I think JDRF has done a really terrific job in making sure that people understand that type 1 diabetes can be diagnosed at any age. But if it is diagnosed in childhood, those kids grow up and become adults. And so support is needed across the lifespan. So hopefully that explains that for Theo. But so how are you using this report to benefit that type 1 community that we're talking about?
So this report's going to be used to bring attention in an evidence-based way to the true scale of type 1 diabetes in Australia and its cost and burden. That in turn can be used to demand action, and that action can be used to inform investment. Now that's a relatively linear pathway. It never works quite that easily. What we'll also do is bring it to the tables of people like Diabetes Australia and our other colleagues in the Diabetes Alliance and say, hey, what does this let us do together that we can't do alone? And it really provides a bit of a rallying cry or more ammunition for the existing strong relationships in the sector to try and aim for even more outcomes and outputs. Some of it will be through governments, some of it will be through philanthropy, some of it will be just through provision of support and information to the community. There's a whole bunch of different angles in here that this report can help inform. And it's our report in that we commissioned it, but in no way do we see it as ours. This is a community asset. We'd like it to be used by the community in any way that they see best, because the statistics and the information there is very compelling.
Absolutely. And I know that Diabetes Australia certainly will be using this in our advocacy efforts, but let's backtrack to something you said there. You said the Diabetes Alliance, the Type 1 Alliance. Let's talk about that for a little bit, because that's something that we use internally, but it probably doesn't necessarily make all that much sense to people out there. Do you want to take that and explain who we are and what we do?
Let me get a shot at it and you can add to it. So
yeah, sure.
It's a real sign of the diabetes patient group and professional group community putting the patient first. We get together, and by we, it is Diabetes Australia, JDRF, the Australian Paediatric Endocrine Group, the Australian Diabetes Scientists, and the Australian Diabetes Educators Association. So you cover health professionals, scientists, endocrinologists, and patient groups. And together, we're in a place to actually put our shoulder behind some pretty big wheels. As an example, when COVID hit last year, that group was convening weekly to understand how we could better inform and support the local type 1 and type 2 diabetes communities with contemporary information validated to the best of our ability from all of the sources we could bring to bear. So the short answer is it's a bunch of organizations. The longer answer is it's a real engine for doing things on behalf of the diabetes community in a coordinated and collegiate way.
Yeah, and I think the thing about that alliance is that we have our two organizations, so that brings that lived experience, and which is, I agree, has to be the cornerstone, like the real foundation of any advocacy efforts. But on top of that, then we've got the evidence, we've got the research from pediatric groups right through to adult groups, from all health professionals across the spectrum, from researchers. We're a force to be reckoned with, and I think that we've really had some massive wins, haven't we? I mean, let's talk about, just for a second, we've mentioned technology, and I know that that was something that, is really important in this report, but CGM subsidy was, really a very big focus of this group, wasn't it?
Absolutely. So let's acknowledge and be honest about the fact that we're not where we want to be yet. There's
Yep.
so much more to do, but
Yes.
let's also look back and say a decade ago, there was no public reimbursement of diabetes technologies in Australia. And we saw a pipeline of incredible things coming down.
Yes.
Pumps, sensors, next generation sensors, integrated units, semi-closed loop systems. If we didn't have a foot in the door for reimbursement, there was a danger of the first step being too big. So with that group, we got the insulin pump program, and then the first CGM investment made by government. Then its value encouraged a second round of investment. So we're not where we need to be, but gee, that group having a unified voice and all saying this is right. It's right for patients. It's right from the health professional. It's right from the scientists. It's right from the endocrinologists. It couldn't be ignored.
And it's right for government. And I think that that's thankfully that we had that. But I do want to, just reiterate that we're not done. We're not done. And I also want to say, and this is public record, it's available, that because often we are, that age barrier is real, and we hear that. That was never part of, I guess, our initial submissions, was this should only be for kids. We very much were strong on the evidence. Decisions at government level are interesting. We're thrilled, absolutely thrilled that we have had that investment, but we know that there's still so much that we need, and we're continuing to do that.
Exactly. And JDRF's focus for this coming election, and we'll be engaging with the Alliance, of course, is to remove those age and other limits that are arbitrarily applied. Why should a 21st birthday be a penalty? It should be a celebration.
Yeah. So we've got a question though about that extends on that. We've spoken about CGM, but also insulin pumps. Gordon says, what about better access to insulin pumps for older people? So we know that the NDSS covers insulin pump consumables, so the bits that we need to change in and out and throw away after 3 or 4 days, but pumps are still only really subsidised in small numbers. Tell us about the insulin pump program.
So the insulin pump program is targeted at people with the most socioeconomic need. And so it is a relatively small proportion of people. And then we know that at the other end, there is private health insurance that at the more expensive end can provide for access. There's an enormous gap in the middle. And so that questioner is absolutely right. And so part of the more technology for more people proposal that we're trying to encourage government to invest in is insulin pumps, not just CGMs. They're both important, and increasingly they're important together in combination. And increasingly so into the future. So absolutely, how we encourage government to see the human, the clinical, but also the financial benefit. And so one of the things from the report is that investing in that ubiquitous access, CGMs and pumps, to those who choose to use them, whatever model and whatever manner they choose, would be able to deliver around about a 14% cost reduction over the life cycle of an individual, as opposed to what would be the case without access to that technology. So that's evidence that we can use to make this case and take another step towards technology for whoever wants it, whenever they want it, in whatever manner they want it, as we would do for other conditions like a hearing disability that requires a cochlear implant. We don't restrain you from getting it because we don't like your age, and we don't take it away. We don't take it away from you when you turn 18 or 21.
That's right. And I think that's, one of the things that we are going to be seeing. I mean, we've already heard that people are aging out of the current access programs and initiatives. So how do we make sure that that doesn't happen and support people who were never covered in the first place? But
if there are people on this call who have either aged out of a current access program or who are too old for a current access program and have a story they'd be willing to share as part of us bringing attention to the human side of what we now have, the economic and financial evidence, please reach out to JDRF, because we would love to have your voice alongside others who can remind people how important that investment is.
Absolutely. That's so important. So let's talk about this. I know that the team at JDRF would be getting this, as do the team at Diabetes Australia. We have people saying, what can I do? What can I do? We understand that you're doing your bit, But what can we, as people living with diabetes, affected by diabetes, loved ones of people with diabetes, what can we do to help with this? How can we advocate for more access? And I always say to people, never underestimate the power that the individual has in adding to that collective voice. This report is going to be an absolute goldmine for people, though, isn't it? To show when, go to your local MP, and what can people say? How can they use this report?
Thinking about going to a local MP is sometimes daunting for people, but it really doesn't have to be. Let us do the work with Diabetes Australia and other diabetes organisations of making the really strong proposal with the economic modelling. That's not the job of a person who has a family member affected by type 1 diabetes telling their story.
Yeah.
We just need to go to the MP and we ask our families to tell them about life with type 1 diabetes and to ask that they remember that family when making decisions about policy into the future. Now, we've got something else we can add to make it a bit easier to make it real for that MP, because the human voice is important, but some of this evidence, which is a bit unwieldy in the report to be used in an MP meeting, we might be able to make it a bit easier for people to use in that environment. So if I'm able to share my screen.
Yeah, let's see if we can do that. We might need Em or Bridget to make that
allow me.
Yeah, but if we can do that, but let's keep talking in the meantime, and then we'll.
What's your local member? Who's your local federal member?
Me.
Yes.
Yeah, it's Peter Khalil. I'm in Wills.
Peter Khalil Wills. Okay, let's look up Peter here. So see if I'm able to.
Oh, we are now sharing your screen. Awesome. Look at this.
You can see that screen. So imagine you're going along and you've never met an MP before.
Yes.
We've distilled the information in this report into a picture for Wills.
Wow.
And for every other electorate in the country.
Yeah.
And we've taken information that we've also gleaned from the wonderful NDSS map that Diabetes Australia has produced from its work, and added to that what we can get from this report at an electorate level.
Yeah.
We can bring to life what it means, the terrible burden of complications. We can bring to life the reality of cost at an electorate level, the people who are going to be diagnosed, the number of people affected, the people with stage 1 and stage 2 type 1 diabetes, which many on the call may not have heard of.
No, we're going to talk about that in a minute. Wow. Yeah. All right. Yeah.
Your immune system starts to malfunction before it manifests as what we'd currently consider a diagnosis.
Yeah.
The emotional burden, the anxiety and depression, and last of all, the number of people who don't have access to technology. And if you're an MP and you're seeing numbers like this in an electorate where you've got a margin of a few thousand people, they make it real. And that plus the human story can hopefully make a really compelling pitch in a very casual meeting. It's a one-pager that just takes this report and says, here is a tool, here's a piece of ammunition for you as a family to use. Get that meeting, tell your story, tell them about why it's important, and ask them for help. That's hopefully a bit more straightforward.
This is so neat, isn't it? Just look at how, it's concise. There's not a heap of stuff that anyone needs to work through. There are really great key points that, as the expert living with our own diabetes, we can point to. And it's not just talking about one aspect of diabetes, it's talking about everything in there. It's talking about the mental health burden as well as, complications. It provides a really neat, tidy picture, doesn't it, of how type 1 diabetes impacts on the areas that we live. And, I can just see how powerful this is. I do know Peter. I have absolutely picked up the phone and had a chat with him, and I went and heard him just last week. He was speaking at because I live in one of the most hipster areas of Melbourne, at a local pub. This was obviously before lockdown, and he was there with Tanya Plibersek, and I went with my mum and heard, and people were asking questions. This is such a great thing to be able to I guess to take to our local members. But I do want to pick up on something before we then talk a little bit more about those advocacy efforts that we can do and how we can use the report. Talk to us about stage 1, 2, and 2 type 1 diabetes. We talk about pre-diabetes, but we're always talking about type 2 diabetes there. What are we talking about here with type 1?
So for type 1 diabetes, the traditional definition of diagnosis is when people present because of the loss of beta cells to the extent that the elevation of blood sugars causes real problems. That's known by probably everyone on this call.
Yeah.
What we've defined in recent years with expert input and with the validation of international scientific community has been the early stages that are actually on the road to type 1 probably unstoppable, but could take months, years, or even decades to unfold. The first step is when your immune system starts to malfunction and destroys its own insulin producing cells. So you have autoantibody positivity and you start to show signs of that decline, but nothing happens to your blood sugars. Then after a bit of time, stage 2, that decline induces fluctuations in blood sugar levels that aren't seen as what a healthy system would be able to generate. That's stage 2. Then over time, that presents as stage 3, which is now clinical diagnosis. What that means is there's actually way more people who are on the path to type 1 diabetes than they may realize. And that's a nod towards the need for general population screening and interventions now, as people may have seen last week, the first ever drug that has delayed the onset of type 1 diabetes by 2 years. And if we can do 2, we can do 5. If we can do 5, we can do 10. If we can do 10, we can do forever. So understanding, identifying, and then intervening in stage 1 and stage 2 is the pathway towards total prevention. But we never quantified that before this report.
Yeah, and I think that that is just some really valuable information to be able to talk about. To be able to start talking about this. These. I don't even know what we're terming it. We can't. I mean, pre-type 1 diabetes, is that what we're, whatever the language that we're going to use is. We haven't been able to do that before, and being able to do that now is really, really useful when we're thinking anything to do with type 1 diabetes, isn't it?
Absolutely, and in fact, we're not even calling it pre. We're actually saying that's type 1.
Right.
It hasn't manifested yet in what we would have traditionally called clinical diagnosis, but it's most likely that we'll have numbers that show, around 50% of people will be diagnosed from stage 1 to stage 2 in a period of time X, and then stage 2 to stage 3 takes another period of time. But saying that to Peter Khalil, that there are 167 people, that's also 167 stories that if we don't do something are going to end up with a pretty terrible diagnosis, most likely. The burden for the individual and the family. So that's a very real connection to the lived experience of whoever's giving that message.
Absolutely. So we've got a couple of comments in here. One from Catherine Forbes. Hi, Kathy. Aging out is a huge issue. My daughter's turned 21 and she would have lost all access to her technology that she'd been using for many years. And she says, thankfully that we've been able to finance this for her so far, which is great when we've got parents who are able to, but we know that obviously that's not the case for everyone. But she says, sadly, this does not allow her to step forward into adulthood and become independent, which is something that all people at this age desperately want and need to do. We hear you, Catherine. These stories, we hear them, don't we, Mike?
It is. And if it's the Kath, I think it is. I've known Kath and her daughter for many years. And I find it personally affronting to know her daughter and have to say to her, we haven't yet fixed that. That's really I find that immensely frustrating, but that is our focus and that is our absolute goal. So you're right, Kath, there's nothing other than to say you're right, but the voice that you've brought and that your daughter can bring and others like you can bring will make it an unstoppable force for this election, because we want to go into the election with bipartisan commitment. We don't want to make it a party policy. This has to be something that every side of politics gets on board with. So we celebrate when the second announcement's made in the election campaign. We don't wait for the result on election night. You can vote whatever way you vote, but we're going to get the result we want, whatever happens.
Yeah, and that I can still remember when, I think it was back in 2016 when we had that bipartisan support about CGM funding, when we didn't have it yet. And gosh, that felt like, it felt like a win for us that we had both major parties saying, yep, absolutely, and if we get in, we will support this. So it wasn't that we didn't care about the result of the election, because of course we do. There are always other things to think about, but knowing that, and that's why the support, I guess, of the alliance being able to really push for that is so critical.
Absolutely.
Now let's talk about technology more broadly than we have spoken about CGM, but we know that there is always other stuff coming, isn't there? Whether that be hybrid closed loop systems, whether it be different technology. We've got a question specifically about the Omnipod, which we know is being launched into Australia. Can we talk a little bit about what our alliance is doing in terms of looking at, we don't look at specific things, we look at broad, I guess, the different systems broadly. What are we doing to try and encourage that support? And while you answer that, I'm low, I'm going to have some juice. Excuse me.
Gotcha.
Yeah.
So it's so exciting on one hand to see so many different varieties of technological solutions coming down the pipeline, things we wouldn't even have thought possible, including things like connected pens and other units,
Yeah.
CGMs, new CGM entrants, different types of pumps, disposable pumps, patch pumps, hybrid closed loop systems, hack systems. It's fair to say that the Australian reimbursement and regulatory environments are almost completely unprepared for responding to these.
Mhm.
And we don't want to wait years for that to be addressed. So part of what the Alliance is doing is demanding from government, from regulators and from reimbursement organisations, a better understanding of how will you assess and decide which of these you pay for? How will you regulate these if they don't fit into current regulatory boxes? We're working with pharma companies to understand, as much as is publicly allowable for them to share, what their pipeline looks like, so we know what the next problem is going to be and we can add the patient voice to it. We're working with the department and with the Medical Science Advisory Committee about the way in which they're going to consider and assess technologies to make sure that they're informed of the way in which we think they should be assessing these. And of course, the clinician voice is very important as well. So while winding all that together, the Alliance has an important role to play, not to pick a technological winner, but to make sure that the foundations are there for any technology that proves itself to be made available to someone as soon as it's proven to be safe.
Yeah. I think what you said there is really important as well. We're not about saying this is the best, use this. We've never been about that. We're about making sure that there's lots of options available, and then people having, deciding and making that choice for what works best with them, because there is no one size fits all when it comes to type 1 or any type of diabetes.
Yes, if we get to a point where the decision about the technology you use is based on your personal choice and the professional advice you get, that's what we want. Right now, it's overlaid with how much does it cost, and can I even get it here because the government hasn't reimbursed it, hasn't had regulatory approval. They're the factors we need to strip away, so it's down to what you want and what your clinician will support.
Yep, absolutely. Now, if we've got any last questions, please do get them into us, because we don't have much longer, and we do want to get to your questions. I think that, so what's JDRF asking? What are you doing with this report here and now? You did mention in terms of, next election campaigns, what you'll be asking for, but where do you go from here?
So this has got to take a few directions. I think first is, hopefully when we convene the Alliance, and the next conversation I think is in 2 days' time, it will become something that will be able to be used by all in different ways and just raise the level of attention again around type 1 diabetes in conjunction with other work being done in relation to type 2 or other challenges to workforce sustainability. They're all valid. This is just a particular lens that we can bring to the table. There is, of course, the advocacy campaign. We're starting to mobilise around the country for the removal of some of those age and stage restraints for current systems. So anybody on the call who's interested in being involved in that, again, reach out and we can make it relatively easy to be a very powerful voice with your local MP. And if you've got connections into some of the influencers, even better. And more than that, hopefully this report will be a resource that anyone can draw upon to give evidence from an expert perspective that supports whatever case is being made. Because it talks about annual cost, it talks about state health systems and federal health systems, it talks about prevalence and incidence, talks about mental health burden. There are different pieces of information in here that can be used for different purposes. And as I said, it's a community resource. We hope it's used by many, not just by us.
Yeah, absolutely. So let's just go back to that point that we made about people sometimes feeling a little bit daunted about contacting our local member. People really don't need to be. And I think about this from before I worked in diabetes organizations. Now I have no qualms at all about picking up the phone or sending an email. Very much, we are the constituents of these local MPs. But I remember having conversations back then, and this was before pump consumables were on the NDSS. That was the big thing that we were lobbying for then. And I do remember feeling incredibly overwhelmed and scared about contacting my local member, who at the time was Kelvin Thompson. But I did it. And the thing that I remember was just how going in armed with knowledge was really, really important. So yes, we mentioned that hearts and minds thing. Going in and talking about my own story was important, but having this sort of information as well just makes what we have to say so much more compelling. So, I think that this is a gift to people who are wanting to do that sort of advocacy.
Absolutely. And when it comes down to it, we can break down most of the mental barriers about meetings with an MP. You know, can you make a phone call and request a meeting? Of course, anyone can.
Yeah.
Can you tell your own story? Of course. Can
Yeah.
you talk about the importance of technology as a future of management for so many people? Of course. Can you use a few of these stats? Probably.
Yes.
And can you ask them if they promise to do something about that in the future if they get a chance? Probably. And then you've made an incredibly compelling picture for that MP, which they'll remember when it comes up in their party room discussion.
Yeah, and it's not a one-off thing. It is a, you know, asking what will you do, and then following that up, not badgering, but, you know, certainly following that up. And also, if you are lucky enough to live somewhere and have a great network, a community around you, you can do this with them. You don't need to go in alone. That's also something to think about.
And if you turn up with a bunch of friends and families and colleagues, all that means to your MP is it's important to more people. And I think one of the things that people may not easily realize is that MPs expect to be advocated to.
Yeah.
It's part of the job that they look forward to. They much prefer it when it's done well and with a clear ask.
Mm-hmm.
They don't like it when it's very ambiguous. You can have a very clear ask.
Yeah.
Do it very compelling because it's your own story. You're not telling a story someone's asked you to make up your own perspective on. It's your story.
Yeah, that's
really
right.
It becomes pretty compelling.
Absolutely. So, Mike, have you got any? So, what we're going to make sure that we share the link. I know that we already have on our social pages, but we'll be doing it in the comment section of this chat so that people can easily find it and then work out how to navigate to get the information that's relevant to them and their local area. But is there anything else that you'd like to sort of finish up with, final words to share with people?
If the report makes the picture as urgent for you as you know it is, if you want to be part of doing something about it in this election cycle, go to the advocacy page on the JDRF website and tell us you're interested.
Yep.
Whether you have a story that relates to aging out of a program, or a story about how beneficial technology has been to you, or a frustration about access you've been denied because of reasons that shouldn't be denied access, that's all part of making a picture that they can't ignore. When we add that story to what we can do through the Alliance and with our partners, we have to make it something they just have to be on both sides of Parliament committing to before the election.
Absolutely. This is the 100th year, or we're kicking off the 100th year anniversary of the discovery of insulin.
Yep.
Diabetes is everywhere all the time, but at the moment there are celebrations and acknowledgements and great advocacy, I guess, you know, things to launch yourself from. So I will also remind everybody that, you know, keep an eye out on what we're saying around the 100 years of diabetes, and that forms part of the story that people can tell. And we will also share, it's actually just, if you go to the Diabetes Australia website, the thing that you will see at the top of that page is information about that as well. But Mike, thank you so much. It is always delightful to chat with you. I will be speaking with you in 2 days' time, but I'm so pleased that we were able to do this.
Thanks for creating the forum. Always good to chat, Renza. Thank you for everything you're doing.
And everybody, this will remain available on our Facebook page and our YouTube channel as well. We can share the link with you. You can share the link with whoever you'd like. If there's anybody who, you know, wasn't able to catch it live, it will still be there for people to see. But that's all we have time for today. Keep an eye out on future Q&As. Thanks so much to everybody, and take care. We'll see you next time. Thank you.